So my name's Harrison Irons, and I'm kind of based out of Birmingham, but like I said, servicing Sylacauga and a couple other areas around the greater Birmingham area. A little bit about me: I grew up in Huntsville, Alabama. I've been in Alabama the majority of my life. I went to college in Birmingham at Samford University, and I stayed in Birmingham for medical school and residency. I did anesthesiology residency, so I'm a board-certified anesthesiologist. And enjoyed doing anesthesia, but missed a lot of things. Anesthesia is great and wonderful. It's a great necessary service. No one wants to be awake during surgery. But also missed taking care of patients kind of in the long term. I do see a familiar face out here. And so I wanted to kind of get back into a field where I could have a relationship with patients and see them and help them other than just the period surrounding surgery. So I went off to North Carolina to UNC Chapel Hill, whose basketball team's not very good this year, for my pain fellowship, then turned back to Birmingham. And so how did I kind of end up to be in Sylacauga? So I'm kind of part of a greater anesthesia group in Birmingham that services Sylacauga already. And many of you may or may not know Dr. Moe, who's a part of this. We have a couple people that know Dr. Moe, may have had some procedures by him in the past. He's part of this anesthesia group, and so he's kind of willing to step down and maybe get to enjoying retirement life sooner than later, and want to see someone to kind of help and fill that need when or if he is to leave in the near future. I'm going to talk a little bit about pain, about what I do, and just about things in general, but I want to leave a lot of time open at the end for questions. I know you guys are here for food door prizes and probably some questions. So we'll talk about pain and how chronic pain affects the U.S., how we treat it, and then some of the challenges and difficulties we have with treating pain. So pain, I mean, everyone has their own description of pain. Pain is very subjective. My pain is different than someone else's pain. We use different words to describe it. And pain is just described as an unpleasant sensory and emotional experience. And as Vanessa kind of hinted in her introduction, pain is not just what we feel, but it's also the way how we feel about pain. It turns into an emotional experience over time, and it's well studied and documented that pain and mood go hand in hand. Your pain gets worse, your mood gets worse. Therefore, your mood gets worse, and back in turn, your pain gets worse, and down things go. It's very complex. It's not just, our biology. It's also our psychology, our sociology, how we interact with others, and our spiritual experience and everything. It's not just one faceted kind of experience that we have with pain. And then painful generators that we have. We have nerve pain. I don't know if anyone's ever had like a sciatic pain. It's like a nerve pain. We've had a couple people like that out there. And that's very different kind of pain than stubbing your toe. So we have all these different kinds of pain. There's different nerve fibers that are in our bodies that send different signals to the brain that tells us that we're having pain. And all of these painful generators can be individual, they can be mixed components as well. And they're all treated differently. And so, like I've kind of alluded to before, after time when pain becomes chronic, which is defined as pain experience longer than 3 months' time, your brain, the way that it lights up is not the same way that it did at first when you have pain. At first when you have pain, certain areas of your brain light up to say, ouch, that hurts, let's stop doing whatever is causing that pain so that we can continue to survive and thrive as a human. And over time, when pain becomes chronic, it's actually more of an emotional part of your brain that lights up. And so pain is no longer kind of modulated and transmitted by these painful pathways, but more of like an emotional and behavioral pathway. And so we'll get into that a little bit too. So pain is obviously very prevalent. You guys are all here today to hear about it and talk about it. So pain's a lot more prevalent than people think. In America, over 100 million people live with chronic pain, which is 4 times more than diabetes and 10 times more than cancer. And you hear a lot about drugs and treatments and things like that for those conditions, but pain, mostly in the news, has been kind of all bad press. But it's a big problem. We spend over $500 billion a year on pain. That is indirect and direct costs. Indirect meaning, people have pain, they can't go to work, and therefore there's lost productivity. And then direct costs are just healthcare dollars associated with treating pain. So it's a big and expensive problem. The average person can't work 5 hours a week because they have pain. and it prevents them from going to work, which is a staggering statistic. And then the most common complaints are low back pain. Who's had low back pain? Yeah, me too. It's no fun. Leading by headache pain and then neck pain. So back pain, as you can imagine, everyone's hand went up. It's the leading cause of disability in Americans under 45 years old, and it affects more than 26 million Americans in their working years between the ages of 20 and 64. It's a very common thing. I know that I've had pain lasting for more than one day. And, a quarter of Americans have experienced that as well. It's not uncommon at all. And so when treating chronic pain, we don't do a great job at treating it. If you read this, 50% of patients with chronic pain report that they had little or felt like they had little or no control over their pain. Kind of a helpless feeling. 2/3 reported that the pain impacted their overall enjoyment of life. 3/4 reported feeling depressed and having low energy, and then almost 100% of people have difficulty sleeping. And so, like I said before, pain impacts every aspect of your life. If you're not sleeping, you don't get the rest you need. You wake up unrested and your mood gets worse. Your mood gets worse, and that's tied to your pain getting worse, and on and on and on it goes. And so how do we break that cycle, or how do we manage all these different areas that pain affects in our life? Sleep, mood, going out and doing things that you like to do, like going outside today, enjoying this beautiful weather and walking around. And so when patients do have pain, where do they turn to? It's very common, over half, 63%, go to their primary care doctor at first. It's the number one reason to see the doctor. You don't go see the doctor if you're not hurting, but pain is always the number one reason to go see the doctor. 25% see a chiropractor. Chiropractors are much more common than pain doctors around, and they're utilized well, and I feel like they provide a very good service to people. Who's seen a chiropractor before and has gotten better? See? It's wonderful. And then 15% end up on my doorstep, and we go from there. 30% of patients, after seeing their primary care doctor, are not satisfied, and they go see another doctor or specialist. And so in getting treatment for pain, almost 60% of patients report adequate pain relief with prescription medications, while 40% can get away with going to Walgreens or CVS and asking the pharmacist for something out over-the-counter medications and getting pain relief. Another statistic, women are more likely to experience chronic pain and are twice as likely to have headache pain. I don't know many men that get migraine headaches, but I feel like all my poor female friends get migraine headaches from time to time. It's just the way that we were made, unfortunately. So, big topic in the news right now. So what do we do about opioids? It's a hot topic right now. President Trump has declared it a health crisis. There's lots of pressure from the CDC, a governmental agency, putting heat on primary care doctors about guidelines and which they should prescribe and kind of ways they should keep track of their patients on these medications. And it's gotten to be such a headache, most guys are just kind of throw their hands up in the air and say, I'm not doing this anymore, go see a pain doctor. So just to talk about the opioid epidemic, it's a real thing. It may be blown out of proportion slightly, but it is real. So let's talk about some numbers associated with it. From 2002 to 2014, nearly 500,000 people died from drug overdoses. Yes, a lot of people. And then every year this number gets higher and higher and higher. 2014 is the last number I could find. It was nearly 50,000 people had overdosed that year alone. And then the majority of drug overdose deaths, these are all drugs now, more than half of those involved an opioid. An opioid meaning a prescription pain medication or heroin. And then the number now is closer to about 100 people die every single day from an opioid-related overdose. In 2012, 80% of those drug overdoses are unintentional. So we have to say, these were not suicide attempts or anything like that. These were unintentional overdoses. And then, I got my fancy laser here. You can just see over time that all drug overdoses correlate very strongly with overdoses involving an opioid, prescription pain pill, or heroin. So this is a big number. To put it in perspective for you, more people die from drug overdoses per year than car accidents, which is absolutely insane. and then also more than gun-related deaths and more deaths than falling. So, just kind of more numbers, more statistics, basically saying that, this problem is only getting worse. And I think that's kind of where President Trump has said, this is becoming a crisis. Like, look at this. People are dying more from drug overdoses than they're dying in car accidents. Cars are getting safer, but what are we doing to make opioids safer for us? Just more numbers, 70% of deaths related to prescription medications do involve an opioid. So, before all these numbers I'm talking about are just all drug overdose deaths, but almost 3/4 of these overdose deaths do involve a prescription pain medication, or involve a pain medication, and then half of those involve a prescription pain medication, not something that has been bought off the street. So what does this all mean? We've talked about some things, and none of it's really been good news. We basically said that pain is really common. The drugs that we use to treat pain are dangerous. We have a hard time prescribing these in a safe manner. We're kind of coming off this is kind of the setting right now, this challenging period that we're in. Back like in the 90s or so, they made pain an additional vital sign. And doctors were actually getting sued if their patient's pain was undertreated. So we made this big push to really focus on treating pain. And so we're like, whoa, there's really nothing better that we have so far than opioid pain medications. And so we would treat pain, if one was good, then two was better. And then over time, we saw that patients would get intolerant to these medications. They have to keep increasing the doses. And then now we've had about 20 years to look at the data from this, and we can see that over time, treating pain with opioids doesn't necessarily yield better pain control. All it does is increase your risk of overdose unintentionally. So that's why we're now kind of backtracking and saying, well, now what do we do? Because this thing that we thought was going to help us with our pain control isn't helping pain, and it's just causing people to unintentionally overdose day in, day out. So these are other medications that we use to treat pain. Many of you have probably heard of these before, or have been on them, or maybe on them right now. As you can see, when it comes to drugs, our toolbox isn't very big. With opioid medications, there are short-acting forms, there are long-acting forms, there are some that are formulated to be just a little bit different than each other, and then we try to use these other medications in conjunction with those. So the opioids hit one kind of pain receptor, and all these other medications hit other pain receptors. And the idea is that, if we can hit multiple receptors involved in pain transmission, not just the opioid receptor, that everything kind of works better together. It's not necessarily like an additive effect. Basically, 1 + 1 doesn't equal 2, but 1 + 1 can equal 5 when it comes to pain relief using all these different kind of medications. So things that we have are NSAIDs like ibuprofen, Motrin, Aleve, Advil, and Tylenol, acetaminophen. And then we use other medications off-label. The way that these drugs came to be discovered because patients we put on a medication for depression, all of a sudden their pain felt better. And so researchers took this and looked at the fact that actually these medications are used actually in lower doses than what we use to treat depression, anxiety, to treat pain. And some of them are tricyclic antidepressants, which is a really old, cheap drug, a bunch of different drugs in that class. And then other medications like serotonin, norepinephrine, reuptake inhibitors. All these are serotonin, norepinephrine are chemicals floating around in your brain. And if you change the way that the quantities in your brain and the number of these drugs on receptors, you actually change the way your brain perceives pain. So instead of kind of preventing the transmission of pain from a bottom-up approach, you can kind of help control from a top-down approach from these medications. Other medications we use, gabapentin and pregabalin or Lyrica, were actually old seizure drugs. They didn't really work all that well at controlling seizures, but they help a lot with pain, and particularly nerve pain, like diabetic peripheral neuropathy and sciatica, really painful conditions. The other things we have are topical modalities, some numbing agents and topical NSAIDs as well, and then muscle relaxants. And guys, that's it. There's nothing magical about this. That's kind of our toolbox when it comes to medications prescribed. And so, if we look at, I kind of talked about how we looked at opioids now, and in the long term, they don't do a whole lot of good, and they have all these bad things associated with them. Well, these are more bad things associated with long-term opioid therapy. So we get endocrine deficiencies. Endocrine is hormones. And so in men and women, there's a decrease in sex hormones, testosterone and estrogen, and lots of men and even women have to go on testosterone replacement therapy when taking these drugs for a long time. Cognitive impairment. These drugs are very sedating. Your doctor tells you when you take these medications, don't go out and operate heavy machinery, don't drive. And when taking these medications for a long time, it kind of dulls the senses. Anxiety, depression, PTSD worsen. Patients are unstable on their feet for these medications. They can suffer more falls. And other things, other kind of endocrine side effects are from immunosuppression and cardiovascular. These medications also change the quantities of these important neurotransmitters in our body, like epinephrine and norepinephrine, and patients have increased risks of heart attacks and strokes. So as you can see, these are not benign medications, and these are really real side effects. We've talked about sleep a lot, and these medications do decrease your body's drive to breathe, and especially at night, if you have a touch of sleep apnea and you take these medications, it can worsen sleep apnea, especially if it goes untreated, and that can go back and negatively impact your heart function. And then one other thing that many of you may have heard of is that, so our bodies are these wonderful things, and if you put opioids in your system for a long time, your body says like, hey, like my nerves can't send all these messages to my brain because all these drugs are sitting on my receptors and blocking this transmission of pain, so your body kind of like amps up the wiring of all the nerves. And so it's trying to just send these signals to your brain that have been blocked for so long. So it causes something called opioid-induced hyperalgesia. And hyperalgesia is basically saying you have increased sensitivity. You actually have increased pain over time. So in taking these drugs for a long time, pain increases. So things that used to not hurt start to hurt, and things that used to hurt a little bit start hurting a lot. It's just your brain's way of adapting to these drugs in your system for a long time. So I've touched on this a little bit. So there's been this big paradigm shift in treating pain because opioids were the answer, and now as you can see all the side effects and all the poor outcomes, it's not necessarily the only answer. And I'm not trying to say that opioids are all bad, because they're not. When taken responsibly and smaller doses where you can minimize all these side effects that you get from taking these chronic doses over time and escalating doses over time. They're not bad drugs, but it shouldn't be the only therapy employed, and these drug doses should be jacked up to really, really high doses that are unsafe. And so there's still been a paradigm shift. And so we're trying to get patients on lower doses of opioids or off opioids altogether, or employ opioids that have not just one effect on the receptor, but it's kind of like a half on the receptor, half off the receptor to prevent the occurrence of these side effects. And we realize that these drugs are great in short term. Everyone in here, I'm sure, has had surgery. You take these pain medications, your body heals, you're great. You're off the medications, you're good to go. They're good drugs for that, but not necessarily, as we're finding out, in chronic use. So what about pain blocks? I'm sure everyone has heard of someone that's had a pain block or had one themselves. And so I just kind of want to talk about different kinds of pain blocks, or just more specifically, what all these blocks are. I feel like pain block is almost a misnomer, because it's more of an injection, and the idea is that we decrease the transmission of whatever painful generator you have, but it's not necessarily like a block of the pain. So we don't have just epidural blocks and just pain blocks. So we'll kind of go through all kinds of body parts that could have pain, and then possible interventions that we can do to treat those painful generators. So for head pain, occipital nerve blocks are used for something called occipital neuralgia. You have nerves in the back of your head called the occipital nerves that can become inflamed and transmit horrible headache pain from the back of your head all the way to the front. And so what we can do is we can find those nerves, and we can block them with a mixture of a local anesthetic and a steroid, a numbing agent, and an anti-inflammatory medication, and see if you can have pain relief. And if you do, it could be long-lasting, and we repeat those blocks as needed, or we can actually go in and put a needle on the nerve and burn the nerve so that that nerve has died off and can't reproduce that pain for you anymore. Our bodies are wonderful things, and these nerves do regrow over time, but we can always go back and repeat that burning. Botox for migraines does have some added benefits for decreasing wrinkles, if that's okay with you guys. But a lot of people suffer from migraines, and Botox for migraine is a set pattern of injections all in the head and neck that yields really, really good results for patients that suffer from migraines. And then that's a big word, sphenopalatine ganglion block. Is a bundle of nerves that kind of lives in the back of the nose, and it's a relay center. It's a relay center for all these nerves that innervate all parts of the face. We can go in there, we can block that bundle of nerves. People have facial pain from trigeminal neuralgia. It's actually been described as the most painful condition that humans experience, and all kinds of different kind of facial pain. So moving on to the neck and arm pain. I see a lot of patients with myofascial pain. You know, they sit at a desk all day and they carry a lot of tension in their shoulders, and their muscles are just tight and they hurt and they ache. And over time, you know, there's decreased blood flow to these muscles because they're always contracted in a bad way. And you can go in, you can inject medication, kind of break up that really scarred down, hard, adhesed tissue through trigger point injections. And those can be repeated and can be substituted with Botox for long-lasting relief if necessary. And so a cervical epidural steroid injection is for the sciatica of the neck and the arm. Patients have like a pinched nerve in their neck, and they've got numbness and tingling and weakness and pain shooting down one or both arms. And then patients that develop arthritis in their neck over time, where the neck just hurts to move, hurts to look around. They don't have the motion they used to have. They can't look and check their blind spot when they're driving. Probably develop arthritis in their neck. And we treat that through cervical medial branch nerve blocks. We go in, we numb up the nerve, make sure your pain goes away, and then we can go back and burn that nerve off also. So patients develop all kinds of reasons to have low back pain. And then facet joint injections are used to treat arthritis in your back. These bones in your back, over time, they rub on each other, they become arthritic, and they hurt. And we can go into that joint space, inject medications or even stem cells in there to kind of get that joint space to regenerate and become less painful. Another way to treat the same exact problem is do the same thing with injecting the numbing medicine and then burning the nerve if necessary. And then a lot of patients develop pain in their sacroiliac joints, basically the part of your body where your pelvis and your back meet. And as you can imagine, that joint carries a lot of stress and it wears out over time. And so we can go in there and we can inject medication to that joint. And if that doesn't work, or if it does for a while, we can always do the same thing, block the nerves and then burn the nerves. And then patients develop, their discs in their back kind of degenerate over time. We can go in and we can inject the discs and kind of tell the surgeons if they'd be a good candidate for back surgery. And then patients over time, our bones get brittle as we age, and then they may suffer a fall and they'll have a compression fracture of the back. Basically, the big backbones just kind of squeeze and break, and it's called a compression fracture. And it's very, very, very painful, if you can imagine. Basically have your backbone just collapsing on itself. So we can actually go in there and blow that disc, that bone back up with a really strong balloon and then backfill it with cement. It sounds like construction work, it kind of is, but it does provide a lot of pain relief. Those are the patients that they show up in a wheelchair and then they leave walking out. Yeah, it's a really wonderful thing. And so low back and leg pain, or like sciatica pain, we can do injections for those, different kinds of epidurals and different kinds of approaches. And then a lot of these patients are good candidates for spinal cord stimulation. Spinal cord stimulation is a really cool technology where you put these two metal leads in the back space, in the epidural space, where you would do an injection. But you don't inject any medication. You leave the leads in there and you connect it to a battery pack. And the battery pack is tunneled, kind of like a pacemaker battery. And so a lot of patients that have had back surgery, that still have ongoing back and leg pain, are great candidates for this. And so the way that this technology works, which has been improving every year, like the iPhone or smartphone in your pocket, it sends current over the spinal cord, and it changes the way that those pain signals are transmitted to your brain. And you don't have to do anything. Like, you don't have to take pills. You just it's all inside of you, and you just turn it on. You have a little remote control, and you don't want to get it mixed up with the TV remote, and it just controls your pain. And then something else called lumbar sympathetic blocks for people that have painful conditions like chronic regional pain syndrome or reflex sympathetic dystrophy. We also treat abdominal and pelvic pain, which is really hard to treat. So this is not all back pain, not all joint pain. A lot of people have tailbone pain. that we can treat with that fancy thing, ganglion impart blocks. And then a lot of patients have pain after surgery. You know, women have had surgery for different women issues or hernia issues and things like that, and we can do nerve blocks, and same thing, burn the nerve if we have to treat those painful conditions as well. And then if you didn't know nerve block for pelvic pain, a lot of bike riders get this, a lot of women get it, just kind of aging and after childbirth. It's pain that kind of sits down in the pelvis. We also treat cancer pain. We try to make patients, if you know they're on their way out of this world into the next, and try to make their departure as comfortable as possible. And we're really bad at treating cancer pain just as a medical profession, or just as like a society of doctors. And so we try to get on board with oncologists to treat pain that have had abdominal pain or metastases to the abdomen that's causing a lot of pain and discomfort. Do something called celiac plexus block. We kind of target a bundle of nerves that is a relay center for all the abdominal organs before it goes up to the brain. And then a lot of people maybe heard of pain pumps, which are intrathecal drug delivery systems, where you actually put tubing into the fluid around your spinal cord and brain. You can pump medications into that fluid, and it hits the same receptors, but as you can imagine, like right there on all the nerves of the spinal cord before they go up. And so it's a great modality for treating cancer pain. A lot of patients back in the 90s had these things put in for treating non-cancer pain, and now we're kind of battling some of the same problems with that as we are with opioids. And then other ways to treat joint pain are through nerve blocks. Like a lot of patients have knee pain. They have had a knee replacement surgery, or they need a knee replacement surgery. And one thing that we do a lot with orthopedic surgeons are genicular nerve blocks. We don't go into the knee itself, we just target the nerves outside of the knee, and we can block those nerves and then go back and burn them if necessary. Same thing with the suprascapular nerve block for shoulder pain. So in summary, I hope you guys learned something. Just want to say that pain management is what it is. It's not pain curative clinic. Sometimes we get really close to that, but you know, this is a lifelong thing. Chronic pain's a chronic condition that we just manage. And we get as close as we can to curing it at times, but it's very difficult. And so it's best treated through medications, you know, a conglomeration of non-opioids and opioids, using therapy, you know, physical therapy, and also, you know, sometimes psychiatric counseling. We talked about all the problems with pain medications and depression, mood, and sleep, and like everything like that. So it's best if we kind of address every aspect of chronic pain in your life. And we went through a lot of procedures, lots of different things that we can do to treat pain head to toe, not just back pain. And then other modalities, other things like TENS units and things like that, back braces, knee braces, chiropractic care, not against anything like that. So our goals are not just pain reduction, but we want to see functional improvement. We want to see you sleeping better. We want to see you happier. We want to see you having good relationships. We want to see you hopefully getting up and walking outside more. These are just a complete list of procedures we do. And then I'd like to open the floor for questions. That's what I'm here for. I want to tell you a little bit about everything, but most importantly, I want to answer your questions. I got a couple questions, I think, before I got here. So my role right now in Sylacauga and Coosa Valley is I come down just for procedures. All the primary care doctors that you guys see have kind of screened you and thought that you could benefit from